Our study really reflects the major unmet need when it comes to resectable hepatocellular carcinoma, which is basically the high rate of recurrence after surgery and the absence of any standard of care approach, either neoadjuvantly or even adjuvantly. So we started our protocol looking into randomization between Nivolumab, anti-PD-1, and combination with ipilimumab, anti-CTLA-4. So the study is one-to-one randomization, 15 patients in each arm, signal finding. And we chose to do this because there is a known synergy and higher response rate when you combine nivolumab with ipilimumab in many diseases, including HCC as well, as reported recently. The study is almost done. We accrued about 26 patients. Thus far, 20 of them got resected. And out of those, 5 patients achieved pathologic complete response at time of surgery, so 100% necrosis. And 2 more achieved major necrosis. So we are presenting our data looking into the predictors of response to therapy. So we were able to identify specific T lymphocytes, CD8 cytotoxic T lymphocyte population, in addition to decrease in T regulatory cells. So the ratio between the CD8 cytotoxic T cells and T regulatory cells, the delta increased. So those patients who had higher ratio, meaning more CD8 and less T regulatory at baseline, responded better. Also, we had more increase in the delta, the difference at time of surgery. The 5 patients were mainly hepatitis related, although we had 2 of them non-hepatitis related. Of course, our study is a small study, so we are hoping that this will lead to a decisive, larger study to change the standard of care. So when you combine PD-1 and CTLA-4, historically in other cancers, there is higher response rate, and in hepatocellular carcinoma this year, the response rate of the combination was also reported to be around 30% as compared to response rate of 15% only with nivolumab, and this is in the advanced disease setting. So we did the randomization based on this promise that we could achieve higher response rate. Our 5 patients who achieved pathologic complete response, 3 of them were on the combination arm and 2 of them were on the single agent nivolumab. Thus far, based on our experience with the combination arm randomized to the single arm, there is some predictors of response at the molecular level based on the immune profiling. So the main 2-cell population was CD8 cytotoxic T cells, and we're reporting on very specific subpopulations of these CD8 cytotoxic T cells in addition to T regulatory cells. We didn't have enough power to look into clinical predictors of response, such as hepatitis status, for example. So therefore, we're launching a larger randomized study. We're looking into a national study in the US under SWOG group, and also we're expanding our collaborations to Europe and Asia, hoping that we can get working with a consortium in the area to launch another study outside the US, specifically in Europe. Our study was not designed or powered enough to change standard of care yet, because we didn't have any randomization to surgery alone, for example. So the next round of studies is going to focus on our approach in a larger cohort, randomized to surgery alone. And this is going to be through SWOG group. We're now discussing the details in terms of the final study design. Also, we're launching another study in Europe with our collaborators from Germany and other countries, and it will be nivolumab alone, randomized to surgery alone.